you for sharing a few minutes of your busy time. So, we're talking about today who are the best candidates for endovascular management of acute deep vein thrombosis. And you're all experienced practitioners, and so you don't need me to show you the nuts and bolts of how to do most procedures. You're well able to do that. I think what is the greatest benefit is to identify those patients who are most likely to benefit from the procedure. And we use this every day, whether it's the size of an aortic aneurysm, 55 millimeters, or the high-grade percentage stenosis in a carotid artery, or the size of a renal cell carcinoma that you're going to ablate, and so on and so forth. And so I suppose the purpose of this few minutes is to share with you the distilled knowledge of all of my mistakes over the last 20 years, but of course, that would take us all day, and in fact, the whole of the Bears meeting just to talk about my mistakes. But I think if we don't learn from each other's mistakes, we're wasting each other's time. And more importantly, I think it's very important for me to share my mistakes with you. Again, we don't have time, but I can share what I have learned as to how not to do it. And that took me a long time. So here we go. So I suppose some very basic things. Although you're skilled radiologists, you're also interventional radiologists. And the first thing you need to do is look at the patient, not the pictures. Because I get sent plenty of patients with an acute DVT. And when I actually talk to the patient, I go out of my way to go up to the ward, or if the patient is sent to my office or rooms. We have a very simple chat while I'm examining and maybe performing ultrasound. The first question, it took me a long time to come up with this, which is a bit embarrassing, but when was the last time your leg felt perfectly normal? Now, see, the problem is a lot of patients are referred with a purple leg, or my leg has been swollen for, or my leg has turned color, or I got these blisters. But when you actually go back into their history, the leg might have been right for 6 months, And why is that important? Well, it's important in acute deep vein thrombosis because going back to a very cellular level, the fibrin receptor sites shut down at around 3 to 4 weeks, and therefore tissue plasma and inactivator cannot penetrate into those sites, and therefore thrombolysis is a waste of time. Not only is it a waste of time, it's putting your patient at risk for bleeding. Now, there are those who would say that with single session thrombectomy techniques, you can take thrombus out up to 2 years. I can't agree with that. I believe that, I'm not saying that it has to be clearly within 3 weeks, but I do believe that the shorter the history, the better you do, or rather, the better your patients do. So, while I'm chatting to the patient, I will be asking them, how do you get on with medications? Do you take your medications? If they've got high blood pressure, do you always take your tablets? Now, I've got high blood pressure, but I'm pretty careful about taking my tablets. And have I missed them? Yes, I have. Usually when I ran out, so I was traveling or something like that. But almost never apart from that, because I know it's important. Now, if I was a diabetic and I was on glucophage or metformin or whatever, would I miss that? I hope not. And yet, I frequently have patients who will admit to me, once we chat to them, that in fact they're not very good at taking tablets and they don't take their anticoagulation regularly. Now, if that's the case, in my opinion, walk away. You walk away. They can't walk. You walk away, because if they won't take their anticoagulation, you're wasting your time with this procedure. You can clear up the thrombus to the best of your ability, and you may be the best in the world. If you don't take the drugs, the anticoagulation happens, you're wasting your time. Now, I know that sounds cruel, but it's true. And it's the same as somebody who's smoking 60 a day and expects you to fix their critical limb ischemia. I don't bother anymore. If they're still smoking, I don't do it. If they're inactive or unable to move, or say post-stroke, or if they're grossly obese or bedbound, I probably am not going to treat that patient, because it's, again, I can clear up the thrombus, place my stent, it'll re-thrombose. So therefore, the patients that you do want to do are those with an acute history, who are younger, who are fit, with no contraindications to anticoagulation, will take their anticoagulation. And in my opinion, at least, it must involve the iliofemoral segment. So it took me a long time to figure this out, but most iliofemoral deep vein thrombosis have a causative stenosis. So look for it, look hard for it, you will find it. I place stents in about 95% of my iliofemoral DVTs, 95%, okay? That's not because I make more money placing stents or I actually particularly enjoy placing stents. I actually find it very boring now. But if I'm going to place a stent, I'm going to do it well. It's another day's work. But most of the patients have a lesion. Now, if you give thrombolysis as opposed to pharmacomechanical thrombectomy or mechanical thrombectomy, you may use slightly less stents, but not much less. You might be as low as 80%. But anything less than that, I think you're missing a lesion. And obviously, CT is different, venography is different than vascular ultrasound. If you've got a DVT and you identify stenosis with intravascular ultrasound, it is real, and that will need treatment, whether it's a balloon or a stent. Before you balloon or stent, you must clear as much thrombus as possible. When I see people saying, yeah, I'll get up 50% of the thrombus and then we stent it, I want to cry, or I want to scream, or I want to do something, because that is not good enough. You need to be up around the 90% mark. You need very little thrombus remaining, okay? Now, we've already talked about this briefly. How often should you stent? So, the big trials, Calvin and Attract, had about 50%, 17% of the iliofemoral group. It was quite a small portion of the overall population, so maybe about 50% overall. But they didn't specify the diameter or whether they had pre-balloon dilatation or intravascular ultrasound before or afterwards. It was quite a long time ago. It was early 2000s. Attract was completed and the results published in 2017. It was only about 60% of the iliofemoral group, so still lower than I would like. Major European centers, in my experience, are around the 80 to 90% mark. And in the recently presented clear DVT trial by Mitch Silver from Cincinnati and Stephen Black from Guys and Tommies in London, the stent rate was incredibly high, when I say incredibly high, much higher than these, so 90% plus. And their rate of post-thrombotic change at 1 year was 4%. 4%, not 47%, 4%, right? So if you do it properly, using all of the attention to detail that you know you can do, I mean, this is chicken feed stuff that you're used to doing, carotids or TACEs or radiofrequency ablation of complex lesions. This is easy peasy, but you have to get the details right. The devil is genuinely in the details. Which cases scare me? And by scare me, I've had bad results. I've had one death on table, and I've had one death. I've had 2 deaths in 24 hours after acute venous thrombectomy. Both of them all of the patients were elderly. The patient who died on table had undiagnosed severe pulmonary arterial hypertension, severe chronic thromboembolic pulmonary hypertension, CTEPH. One of the other speakers has talked about this morning. Pay attention. Those cases scare me. So if the patient has unexplained shortness of breath, prove to me that it is not due to pulmonary arterial hypertension. Prove that to me. If you can prove that to me, fine, I'll buy it. Poor historians, they scare me because if it's not really acute, then the catheter-directed thrombolysis or pharmacomechanical thrombectomy or mechanical thrombectomy probably won't work very well. And therefore you're wasting your time and they're not going to improve. What else scares me? When I can't find a good cause for an acute iliofemoral DVT, what do I mean by that? Well, as I said, most of the cases have a stenosis. But if they don't have a stenosis, why do they get the DVT? Now, all of my patients are seen by hematologists with a specialist interest and expertise in thrombosis, as opposed to myeloma or any other hematology problem. And so therefore, she will ferret through those very quickly and find them. But a proportion of those do have underlying malignancy, but not that many. And occasionally a phlegmasia will make me treat a non-acute iliofemoral DVT with very poor inflow, and my results in those are poor insofar as the stents don't stay open long term. So we've already talked about pulmonary arterial hypertension, and inflow is the key. Inflow is so important, okay? You need to get your inflow as good as possible. Cancer is not a contraindication to active treatment, and always treat the patient and not the pictures. That's really important. I get two viewpoints. In other words, I look at the patient, the hematologist, or hematology colleague looks at the patient as well. This is the Cliffs of Moher near Galway in Ireland. For those of you who come to our little country, it is quite beautiful when the sun shines. If only we had a bit of your Dubai sun. So accurate preoperative imaging is essential. We've already talked about that. Prove to me that pulmonary arterial hypertension isn't at play here. Pre-op imaging is key. You can identify where the thrombus starts, where it ends, where are the areas of compression. All of that is easy for you. You're imaging experts. These are the patients I want to treat. I apologize for showing something like this early in the morning, but it's important because this patient does have a stoma, and obviously he's got a massively swollen scrotum on the left leg. This is him 3 days later. He left the hospital. He died within about 4 months. He left the hospital and he walked out the door. It's really important. Same as this man. This was just a couple of weeks ago. The rash on the right is 4 days after treatment. He's got an undiagnosed, he's got a sarcoma and malignancy, but they reckon it's some sort of extra or a dermatological manifestation of cancer. But look at his leg, it's fantastic. In summary, yes on your left, no on your right. They're the patients you want to treat. They're the patients you don't want to treat, okay? Fairly straightforward. You can do this, okay? Thank you very much for your time.